Okay, we are going to go into Chapter 5, Development of the Nervous System. There is a lot of great information in the book that we will not be covering. In fact, I've taken a lot out of this chapter, so this will be a very short chapter. Um, in the book, the first two major sections of Chapter 5, the developmental stages in utero and the formation of the nervous system, we will not be talking about. We are going to go right to the next section, cellular level development, which is on page 86, and start talking about the cell proliferation and migration growth as part of the development of the nervous system. So all the stuff at the beginning of the chapter happens where the nervous system starts to form and the cells start to differentiate from neural stem cells. But then the neurons migrate out to their ultimate location, their final location, and once they get there, they begin to differentiate. And that's the thing that starts to change their function. So when we start out, we have a lot more neurons than we are ultimately going to end up with. So the function of each neuron depends on the area of the brain from where the neuron migrates. So a lot of the information early in the chapter about the reorganization in cells and everything is very interesting, and it determines the migration of neurons, but I do not expect you to know that. So once the neuron has reached its final location, there is a process, a physical process that emerges from the neuron cell body, and it expands to form a growth cone. When the growth cone contacts the target cell, it starts to form synaptic vesicles and the microtubules that are going to connect the growth cone to the presynaptic membrane. So the connections that the neurons make with the muscles actually sculpt the developing musculature. So muscle fiber type, I know you've probably talked about this in A&P, or if you've had any kinesiology classes, the fast twitch and slow twitch muscles, which we'll revisit a little bit in the motor nerve chapter. But the muscle fiber type is dependent on its innervation. So what will ultimately become fast twitch muscle is converted to slow twitch muscle if it gets innervated by a slow motor neuron. And slow twitch muscle can be converted to a fast twitch muscle if it's innervated by a fast motor neuron. So the muscles develop dependent on their innervation, which is pretty interesting. So the nervous system actually influences a lot of how the other structures in the body develop. So there is a really cool video, and it's slightly less than a minute, that has the growth of a neural growth cone. They actually did it with an electron microscope, and they used a synthetic surface, and they coated it with nerve growth factor, and that attracts the neural growth cone. And it's pretty interesting stuff. He goes into a lot of chemical detail and everything that we just don't need to know, but just seeing the physical process under the electron microscope is pretty fascinating. So there are lots of neurons to start with, and many of them die. As much as half of the original neurons that were in some areas die because they fail to form optimal connections. They're too inactive. So some neurons retract from that area, and then they maintain contact in other areas. So as the nervous system is developing, several axons may innervate one muscle cell. But by week 25 in development, there's only one axon per muscle fiber, and that's how it ends up in the mature nervous system. So neuronal death and axon retraction are what sculpt the developing nervous system. So you start out with twice as many neurons as you're ultimately going to have at the end of development, and some of them die off because they fail to form connections, and some of them stick around. So there's a lot going on in the developing nervous system. And a lot of things can influence how it ultimately ends up, which is pretty interesting. So in terms of myelination, it starts at about the 4th fetal month and completes by the end of the 3rd year of life. So different neurons myelinate at different rates. So the motor root is completely myelinated by about 1 month of age, but tracks connecting the cerebral cortex to motor roots are not completely functional until 2 years. So when you're looking at a baby between 1 month of age and 2 years, there's a lot of motor development going on, and a lot of that has to do with how the nervous system is developing. So the idea of growth into deficit expands on that. So there may have been damage to motor tracts or sensory tracts or some type of neural damage early in the development process, but those don't show up until those nerves start to become myelinated. So they can have deficits that do not show up until 2 years later. So a lot of and we'll talk a little bit about autism, which is actually they've identified which structures in the brain are affected. So it's an early developmental disorder in the nervous system. Probably it's structures that actually develop early in the fetal stages, but the deficit doesn't show up until later because the part of the nervous system that is affected by those structures isn't fully developed until a later age. So kind of interesting, and there have been a lot of things about vaccines, negative information about vaccines and everything causing autism, which at this point has been proven to be false. So there's a really cool time-lapse video of myelination. It's just 46 seconds long because it's time-lapse, and that's a really fun one to look at. So we'll talk about developmental disorders, and there's another video that really has a good description of growth into deficit, which is pretty neat. So really by definition, growing into deficit is that nervous system damage that occurs early is not necessarily evident until the damaged system becomes functional. So there might be some nervous system deficit, some nervous system damage that occurred early in development, but it does not become evident until that damaged system becomes functional. So that's one of the reasons why pediatricians have different developmental tests that they do as your child is growing up. They're trying to detect if there are any deficits in those first couple years. So we talk about critical periods during development, and the critical periods are crucial for normal outcomes. So this is a critical period is when neuronal projections are competing for synaptic sites. The nervous system is trying to optimize neural connections during the critical period. So there's this study where they took baby monkeys and they sutured one eyelid shut from birth to 6 months of age, and they permanently lost vision in that eye even after the sutures were removed. That part of their visual cortex did not develop because those neural connections just were not made. They did the same thing with adult monkeys. After the critical period, they sutured one eyelid shut for 6 months, and there was no effect. The monkeys didn't lose sight in that eye. So during those critical periods, the nervous system has to be stimulated in order for those structures to develop. So interruptions in development during a critical period can cause differences in outcome between a brain injury before birth or around birth and adult brain injuries. So adults with brain damage lose descending motor control and other control, but because their development is complete, it doesn't make their dysfunction worse. Those inappropriate connections or abnormal spinal motor circuits don't compound the dysfunction. But if it happens around birth, before the nervous system is fully developed, inappropriate connections and abnormal spinal motor circuits can be formed, and that can compound the dysfunction. So having brain damage isn't good at any age, but it's worse before your nervous system is developed, if that makes sense. So the central nervous system is most susceptible to major malformations between day 14, that's day 14 after conception, and week 20. So most major deformities of the nervous system occur before week 20 in your utero, and most of these are due to gross structure development in the CNS during that time. So that's when the gross structures are developing. That's sort of the part at the beginning of the chapter that we didn't really talk about, but when the big areas of the brain are being formed are between day 14 and week 20, and so if anything happens during that period, that's where a major deformity can occur. And a lot of times, if it's a big enough deformity, it will result in a miscarriage. The baby won't ever develop and get born. After week 20, minor malformations occur. So that a lot of the developmental disorders that occur after week 20 are a little bit smaller. Major deformities are before week 20, between day 14 and week 20. So I really want you to know those critical periods, and know that major deformities occur before week 20 and minor malformations after week 20. So the growth and remodeling continue after week 20, but they cause more functional disturbances or just minor malformations, things that you can actually live with and develop. So we're going to talk about some specific developmental disorders. The only ones that I will expect you to know for the test are cerebral palsy and spina bifida, mostly because those are two that we see really commonly in physical therapy throughout the person's lifetime. So anybody who's interested in doing pediatric therapy and everything, pediatric therapy is neurotherapy. And you will, in your neuro rehab class next quarter, you'll be talking about pediatric therapy. This is an area that is outside of my experience. I don't do any pediatric therapy. I work with adults. But if you want to work with peds, you're going to be working with neuro. Because children with orthopedic injuries often don't need physical therapy unless they have major orthopedic injuries. But children with developmental disorders and nervous system disorders often need physical therapy throughout their life. And we'll talk a little bit more about that too. So just remember, major deformities in the nervous system occur before week 20 due to gross structural development in the central nervous system, and minor malformations after week 20. Okay, there's a little 5-minute video on the development from conception to birth, which is pretty cool animation. It's fun to watch. So during those critical periods, again, the neuronal projections are competing for synaptic sites, and the nervous system is optimizing the neural connections. So that's why those periods are so critical. So we're going to talk about some different developmental disorders, and then we are going to talk a little more specifically about spina bifida and cerebral palsy. So there are some that are considered to be neural tube defects. Anencephaly is a neural tube defect, and it basically, there's a formation of a rudimentary brainstem without cerebral or cerebellar hemispheres. So you can imagine that is a severe defect. It occurs when the cranial end of the tube remains open and the forebrain doesn't develop, and the skull doesn't form over the incomplete brain, leaving the malformed brain stem and meninges exposed. Sometimes babies are born with this deformity. It's very rare. They usually don't survive to birth. And you can imagine that the prognosis is not very good, so this is not something we see in physical therapy very often. Another neural tube defect is called an Arnold-Chiari malformation. It's a developmental deformity of the hindbrain, and the type 1 is often asymptomatic. Some people have type 1 and they get into adulthood without even realizing they have it, and they might have some symptoms later on and find out they do have it, and it's a surgical correction. So type 2 causes progressive hydrocephalus, so fluid building up in the brain, paralysis of the sternocleidomastoid muscles, deafness, blindness, weakness of lateral eye movements, and facial weakness. The reason all of those things are affected is the brainstem is actually coming out below the foramen magnum of the skull. So the brainstem is exposed more than it normally is, and the cranial nerves come off the brainstem. So all of those things except the hydrocephalus, but the sternocleidomastoid muscle innervation, hearing, weakness of lateral eye movements, and facial weakness, those are all controlled by cranial nerves. And so a lot of times in type 2 and often in type 1, even though it's asymptomatic, cranial nerves are affected. So again, because it's a lot of times it's asymptomatic, and these are things that we can't really treat in physical therapy, you do not see this very often in physical therapy. And it's usually corrected surgically. So spina bifida, on the other hand, we will see fairly depending on where you work, fairly frequently in physical therapy. I have worked with a few adults that have different levels of spina bifida, and of course they were born with it, and one of them uses a wheelchair for mobility. One of the people with spina bifida that I've used a lot, one of them that I've treated a lot, one of them uses crutches for mobility, and a wheelchair for long distances. And some of the lower level spina bifida people walk normally, and they don't, they have some symptoms, but it's much less affecting to their lives. So we will talk about I'll talk more specifically about spina bifida, and we'll talk about the different types and the prognosis and the physical therapy treatment. But we'll talk about a couple other developmental deformities first. A tethered spinal cord is where the cord adheres to a lower vertebra. So a lot of times it is not noticed until the person starts to grow, because there's not tension or traction on the cord until the person gets bigger. So it's not noticed until adolescence or later, when the person kind of has their growth spurt. So it can cause dermatomal and myotomal deficits in the lower limbs, pain, they call it in the saddle region, you can imagine where that is, and the lower limbs, and bowel and bladder dysfunction, because those nerves at the end of the spinal cord and the cauda equina often affect that bowel and bladder function. So sometimes, if it's depending on where it's tethered, where it's adhered, people might only have mild signs, or if they're sometime when a mechanical stress increases, like if they're doing some type of movement that is increasing the traction on the tethered spinal cord. So that's also corrected surgically. And I've never worked with someone with tethered spinal cord, even though I've worked with a few people with cauda equina syndrome, which we'll talk about in the spinal chapter. But it's kind of an interesting thing. You might have it and not know it until you get older. So cerebral palsy is it's a movement and postural disorder, and its hallmark is that it's permanent and non-progressive. It's permanent, non-progressive damage of the developing brain. It can include cognitive, somatosensory, visual, auditory, and speech deficits, and growing into deficit is common, meaning there could be some deficit there that you don't find out about until later, until that system comes online. So obviously if you had a speech deficit, when do you learn to talk? When you're a little bit older, you're not a baby anymore, and you don't find out about that speech deficit until that system comes online. So the nervous system damage is not progressive, but new problems may appear when you reach that that time when it would be a developmental milestone. Walking, speech, some of the other developmental milestones, and so a lot of times you don't really know the extent of the damage until the person starts to grow up. So CP is usually classified according to the type of motor dysfunction. So there are 4 different kinds, and then the 5th one is mixed, which can include any of those 4 kinds. So spastic, and that is caused by damage to axons adjacent to the lateral ventricles. Dyskinetic, and that's neural damage in the basal ganglia, which has a lot of control of our movement. Ataxic, damage in the cerebellum, and the cerebellum also has a lot of function on movement, and we will talk specifically in later chapters about basal ganglia and cerebellum. And hypotonic, so the site of the damage is unknown, but people have low muscle tone and difficulty controlling their muscles. And then mixed, it could be any combination of the above. So CP was traditionally believed to result from difficulties during the birth process, but there have been a lot of studies that indicate that about 80% of cases, so difficulties during the birth process, like a good example is the umbilical cord is wrapped around the baby's neck and the brain is deprived of oxygen for a certain amount of time during birth. But 80% of cases result from events occurring before labor. So it could be a genetic defect, it could be a metabolic problem. So the baby's not getting, that's developing brain is not getting the proper nutrients because there's a metabolic issue with the mother's metabolism. Immune problems, coagulation disorders, maternal infections can cause problems, and endocrine and metabolic disorders in the mother can actually cause those before the baby's even born. So hypoxia during birth, which was originally believed to be the biggest cause of CP, is rarely a cause of CP. That's the current thinking. So we'll talk a little bit more about the physical therapy for CP and that sort of thing later. A lot of times, people with CP, you are working with them on and off throughout their lives. And I've worked with a lot of adults with CP, and all sorts of different kinds. And so it's really kind of interesting. And adults that have CP, they can lead normal lives and have children and do everything that everybody else does. So there's a lot of people out there with CP. So even though I'm not going to test you on this, I just think it's interesting that attention deficit hyperactivity disorder, or ADHD, is now classified as a developmental disorder. So it's the developmentally inappropriate inattention, impulsivity, and motor restlessness. And they have found that the volume of several structures, the prefrontal cortex, the caudate, the putamen, dorsal cingulate cortex, and the cerebellum is reduced. So that's interesting. So when all that feeds into, there's less dopamine available and norepinephrine for mental function. And so the drugs used to treat ADHD are stimulant drugs, and they work by increasing the availability of dopamine and norepinephrine in the synapses. And that improves function for some people. So I thought it was pretty interesting that between 3 and 7% of school-age children are affected by ADHD. So, if you're a teacher, you could easily have 1 or 2 kids in your class that have ADHD. So, kind of interesting. So, the autism spectrum disorder, they talk about 3 different ones. The autistic disorder, Asperger's disorder, and pervasive developmental disorder, which is sort of not, it's a one by exclusion. It's not autistic, it's not Asperger's, it's something else. So people with autistic disorders engage in repetitive behaviors, have limited interests, appear to lack imagination, and are not interested in interacting with others. So that it's kind of interesting. So people with Asperger's, they speak and they have normal or higher intelligence than normal, but they have limited social skills and a narrow range of interests, and frequently have repetitive and obsessive behaviors that interfere with their normal functioning in life. So someone with Asperger's can be highly intelligent, and even though they have limited social skills and a narrow range of interests, they could lead a fairly normal life, and actually be quite high achieving, which is kind of interesting. But individuals with pervasive developmental disorder, they sort of have some atypical behaviors similar to autism or Asperger's, but they don't necessarily meet all of the criteria for either one of those diagnoses. So they're sort of, they say, well, it's similar to Asperger's or autism, but they don't meet quite all of the criteria. So usually infants develop signs of autism a little bit later in their development, and they start to show traits at 12 months of age. And the things that they start showing is poor eye contact and decreased shared attention. And by that they mean, how with a little kid you might say, hey, look at that, and they'll look. Well, a kid with autism, they will not do that. They will not share attention with you. They will not pay attention to something that you indicate, or point out something for you to pay attention to. So they have poor communication and poor social interaction. So brain differences in autism include reduced communication among cerebral areas and a larger than normal amygdala during childhood, which they haven't really determined what that larger than normal amygdala, what its meaning is, or how that affects things, but that's physically what they have found in brains of people with autism. So that's interesting. So when we were talking about the glial cells and the communication of the astrocytes with the neurons, and someone like Einstein who's really intelligent having increased number of glial cells and increased communication among cerebral areas, people with autism have sort of just the opposite. So kind of interesting. And they also have some abnormal shape of the caudate and putamen, which are 2 of those nuclei in the brain, and they correlate with motor and social and communication impairment. So there are actual physical impairments in autism that they've identified in the brain. So it is a developmental disorder that probably happens before birth, but because of that phenomenon of growth into deficit, when they do not begin to show traits of the autism until those systems that are affected come online, basically start being used, and so then they start to show their deficit. So current research has found that no relationship exists between the MMR vaccine and autism. The physician who reported the association originally has had his medical license revoked for misconduct specific to that original study, and the journal that originally published the study fully retracted the article. So unfortunately, that caused a lot of repercussions in parents not wanting to get their children vaccinated, and that can be a big problem down the line. But so it's, even though a lot of publicity was made of that, there is no relationship between the MMR vaccine and autism. It's actually a physical brain disorder, physical brain developmental disorder. So I'm not going to have anything about autism on the test, but I just thought that the information that they had in the book was really interesting, and I wanted to talk about it with you. So we'll go back to spina bifida and CP, and this is the information that I do really want you to know. So with all of the pathologies that we'll study, I kind of am following a similar framework in that, just like we did with MS and Guillain-Barré, we're going to do the same thing with spina bifida. We're going to talk about the pathology, the etiology. So pathology is what is the defect, etiology is what caused it, signs and symptoms, that's obvious, medical treatments, if there's a medical management, like we've been talking about the MS medications on the discussion board, and then the PT intervention. So that's what the rubber hits the road for us in PT. So with spina bifida, it's a developmental abnormality where the inferior neuropore doesn't close, or the vertebrae do not close around the incomplete neural tube. So there are 4 different types of spina bifida. So occulta, and if you think of occult meaning hidden, whatever, occulta, there's no neural tissue protruding through a bony defect, and the spinal cord function is usually normal. So that's probably like the least affecting form of spina bifida. The next one is the meningocele, where there's a protrusion of the meninges through a bony defect in the vertebra. That one may also be asymptomatic, but someone might have impaired spinal cord function with that as well. With the meningomyelocele, actual neural tissue protrudes outside the body. And with this one, you get lower extremity dysfunction, and bowel and bladder function is impaired as well. With the myeloschisis, or gosh, I can't say that word, myeloschisis, it's the most severe defect. You have a malformed spinal cord that's open to the surface of the body, and so of course that one is the most severe. So people with the last two, meningomyelocele and the myeloschisis, might have to have surgery. They might not be able to walk at all, or they might need assistive devices to walk. They might need to use a wheelchair for mobility. So those are the most debilitating. So the etiology of it is it's sometimes due to a nutritional deficit. It's a deficit of folic acid. And so anybody who's planning on having children or trying to get pregnant should be taking folic acid to make sure that they don't have that nutritional deficit. And I've even read some sources that say both the mother and the father should be taking folic acid. There's a little video, just under 5 minutes, talking about spina bifida, which is quite good. So with the signs and symptoms, the occulta, there's no neural tissue protrusion and no signs and symptoms. So the only way they're going to detect it is looking at an x-ray. So it just might show up, you're having a routine x-ray for something else, and that defect shows up, but you don't have any signs and symptoms. So with the meningocele, signs and symptoms can be variable depending on the area that's affected and the severity of the malformation. With the meningomyelocele, it always has lower extremity paralysis. It varies according to the level of the spinal cord that's affected. You can have sensory deficits in the lower extremities and lack of bowel and bladder control. And with the myeloschisis, you might require surgery even to survive. So, and of course, even after surgery, that person is probably going to have the lower extremity paralysis as well, and sensory deficits and lack of bowel and bladder control. So for medical treatments, if it's unstable, they might need surgery. Otherwise, there really is no medical treatment for spina bifida. So surgery to correct if necessary, and then otherwise it's all physical management. So for PT intervention, a lot of defects, a lot of developmental defects or genetic defects result in low muscle tone. So a child with low muscle tone needs stabilization, and you will talk more about that in your neuro rehab class. So a lot of times they might need, if it's someone who uses a wheelchair for mobility, they might need side pads in their wheelchair to make sure that they can hold their torso upright. They're going to need strengthening, range of motion, they might need bracing or ambulation aids, and they might need a wheelchair for mobility. And so a lot of times we are working on all that stuff in physical therapy. An adult who has spina bifida often might have some, be coming into physical therapy for maybe they were walking with 2 crutches, but their ambulation has gotten much more difficult and they have to come in and get fitted for a wheelchair. Sometimes they're coming in for strengthening or range of motion or an issue that is in some way related. I have one adult with spina bifida who has the meningomyelocele, uses a wheelchair for mobility, and as a result of her sensory and motor deficits in her lower extremities, she also has lymphedema. So we work with her frequently, or maybe once every year and a half or so, we work on lymphedema control. So there might be a secondary problem that develops because of the other problems. I've also worked with someone with spina bifida on back pain. They come in with back pain, and so we're working on strengthening, stabilization, range of motion, possibly manual therapy for helping them get through their back pain. There's another little video that has some nice animations on spina bifida. So CP is the other developmental disorder that I want you to know about for the test, and you need to know that the pathology is it's a non-progressive damage of the developing brain. So once the damage has occurred, it does not progress beyond what has already occurred. The etiology can be abnormal development in utero, metabolic abnormalities, disorders of the mother's immune system, coagulation disorders, infections, trauma, or hypoxia at birth. So the signs and symptoms, they can have motor, sensory, or cognitive signs and symptoms, not necessarily all of them. So with the motor symptoms, they might have spasticity because damaged neurons cause muscle shortening and stiffness, scissor gait, and toe walking. A lot of times with people with CP, you're working on stretching, and hippotherapy is common, which is horse therapy, because a lot of people are really tight in their adductors, and getting them on that horse stretches those adductors out really well. So I've worked with a lot of adults with CP working on muscle spasticity. Athetoid is a motor symptom that is a slow writhing movement. There are some other illnesses that cause that same slow writhing movement, like Huntington's, which is a genetic disorder, and we'll talk about that when we're talking about the basal ganglia. So those slow writhing movements are caused by damage at the basal ganglia, which is one of our motor control systems. So ataxia, if you want to picture ataxia, the way someone walks when they've had way too much to drink, that is an ataxic gait. Alcohol affects your cerebellum, so damage at the cerebellum causes ataxia. Incoordination, weakness, and shaking with voluntary motion. Mixed, obviously, combination of all those things, and growing into deficit is common. So a lot of times that some of those things don't develop until the child starts walking or starts doing other things. So sensory with cerebral palsy could be normal or it could be impaired. So it just varies depending on where the damage is. Cognition, language, and memory. There are certain types of damage with CP that present with mental retardation and language deficits, although people with CP can be of normal intelligence and may actually be very bright, very intelligent. So a lot of the adults with CP that you'll work with in therapy are of normal intelligence, they have normal jobs, they have kids, they have lives, and they're dealing with their sensory and motor issues through therapy, which is pretty great that they're able to do that. I worked with this one really amazing young woman who was a paralegal. She used a walker for mobility. She had a couple of surgeries to lengthen her Achilles tendons. I worked with her after both of those. A lot of people, so when we look at the medical treatments, a lot of people have those type of surgeries to lengthen tight muscles because of that muscle shortening and stiffness, lengthening tendons, and sometimes CP can result in seizures, so some people are on seizure meds, spasticity meds, or Botox injections for excessive muscle tone. And we'll talk a little bit more about therapeutic use of Botox a little bit later on when we're talking about the muscle system. So for PT intervention, we're working on, when they talk about developmental sequence, you'll do more of this in neuro rehab, but wherever that child is in their sequence, you're working on motor skills associated with that. Exercises for stretching, coordination, postural control, gait training, bracing and adaptive equipment, hippotherapy, which is the equine therapy for stretching those tight adductors, and for coordination and trunk control. So hippotherapy is kind of a cool area. There's a place out here in Whatcom County that does equine therapy, and one of my interns in the clinic from Western was working out there last summer, and she said it was just amazing, just really super amazing. So if you ever get a chance to be involved in that, that is a really neat area of therapy. So there's a little 5-minute video about CP, and I really like this video because the doctor does a really good job of concisely describing that idea of growth into deficit. So if you have a chance to watch that 5-minute video, it's really worth watching. Other than that, we have covered all of what we're going to cover in Chapter 5. And this is chapters 1 through 5 are all that are going to be on the first exam. And after that, we will start getting into the different nervous system areas of the body, and we'll start talking about the somatosensory system and pain control, which is a very interesting area. So this is a wrap-up of everything that we're going to do for the first exam. Pretty exciting, right? Okay, I will talk to you guys later.